Dr. Dhanya, can you put your slide?
Yes, sir. Visible, sir?
Yes, yes. Okay, today's session is on approach to gate and falls. So other moderator is having some problems, so we can start. So Dr. Somya, you can introduce yourself. Today's moderator is Dr. Somya and Dr. Sheikh Afsar Pasha. He is yet to join due to some technical issues, and Dr. Dhanya is presenting. So you can go ahead, Dr. Somya and Dr. Dhanya. You can introduce yourself.
Good evening, everyone. Myself, Dr. Soumya, and I welcome you all for today's session, and especially Dr. Dhanu for approach to gate and falls.
Good evening, everyone. I'm Dr. Danya. I'm a third year register. So today I'm presenting about the approach to gait and falls. So gait refers to a coordinated cyclical pattern of the limb movements that enable bipedal locomotion in the humans. So major anatomical structures responsible for the equilibrium and locomotion are brainstem locomotor region, which includes subthalamic and midbrain, and cerebellar locomotor region. Also, above both, all the cerebellar and brainstem will project to the pontomedullary reticular formation, and this is also called as mesencephalic locomotor region. And from here, uh, it is projected to from pontomedullary reticular formation. It is projected to the spinal neurons. From spinal subcuneate spinal neurons, it's spinal motor neurons, which will be help in the locomotion. So in detailed anatomical structure we are going to discuss. So brainstem locomotor region and cerebellar locomotor region, which will be projected to the pontomedullary reticular formation. From here, spinal interneurons, also known as central pattern generators, they are projected to the limbs and trunk muscles, which help in the movement. So these brainstem locomotor regions, they stimulate, this leads to the increase in the axial and limb muscle tone, which leads to adoption and maintenance of the upright posture before stepping begins. Whereas the spinal interneurons, also known as the central pattern generators, they drive the motor neurons of the limb and trunk in a patterned and repetitive manner. Basically, there will be a repetition, extension followed by flexion, alternating movements to produce the stepping movements. And these also, the additional sensory input will be received to the central nervous system via proprioceptive system, sensory system, auditory system, and visual system. So further, these brainstem locomotor regions and cerebellar locomotor regions act with by the connections via frontal lobe and its connection, especially basal ganglion, cerebellum, nodular lobe, and anterior lobe and its connection. Frontal lobe mainly helps to modulate the postural responses and enable precise foot movements, whereas cerebellum modulates rate, rhythm, force, and amplitude of stepping, maintains the posture and equilibrium. So, going into the gait cycle, locomotion involves propulsion of the body by sequential stepping movements of the lower extremities in a repetitive gait cycle. Gait cycle is defined as a sequence of movements from a heel strike to the next heel strike of the same foot. So mainly gait cycle consists of stance phase and a swing phase. Stance phase is where the given foot is in contact with the ground. So the heel strikes the ground first, followed by the sole of the foot and then the toes. That is, and swing phase. Given the whatever the foot is there, the given foot is in the air. As soon as the weight is transferred to the supporting leg, once the stance phase is over, the weight is transferred to the supporting leg, the opposite leg will begin its movement. So this is called as swing phase. During the swing phase, the foot must be maintained in a dorsiflexion. From the moment that one heel returned to the ground until the other foot leaves the ground, the body is supported briefly by both foot. This is called double support phase. So we'll discuss one by one. This is the stance phase. This is the initial contact. The heel strikes first. Occurs when the heel is in the right foot contact. Then the here. Next, loading response. This is the initial double support phase, during which the initial contact of the right foot to the ground until the left foot is taken off the ground. During the loading phase, body weight is transferred from the onto the supporting limb from the left to right leg. So next phase is mid stance. This is single limb support. From the elevation, here the left leg is in the elevation phase. So from the elevation of the left leg until both the ankles are aligned in the coronal plane. Next, terminal stance. This is single limb support and begins when the heel of the right leg arises from the ground and continues until the heel of the left leg touches the ground. Pre-swing. This is the next double support phase during the pre-swing. Here, from the initial contact of the left foot to the ground and just before the elevation of the right foot off the ground. So till here is the stance phase. Next, we enter into the after this pre-swing phase, swing phase will start. Here, first phase is toe off, initial swing from the elevation of the right foot to point of maximal knee flexion. And next, mid swing. In the mid swing, the foot clearance following the right knee flexion to the point where the tibia is vertical. That is mid swing. Terminal swing is from the point from the where the tibia is vertical to just before the heel contact of the right leg. This is the terminal swing phase. So next, this shows the graphical representation of the step sequence in a classical normal gait disorders. This is a normal gait where we can see the distance between the. I'll just discuss next about the what is step and stance and all. Like, so this is normal gait. In a spastic gait, the distance between the 2 feet have also reduced, and we can see this step distance is also reduced. Next, shows the cerebellar gait, cerebellar ataxic gait, and here we can see the Parkinsonian gait, and if the shows the represents the frontal gait. There is a narrow step width and the inward rotation of the inward rotation in the paraspastic gait. We can see the inward rotation, broadened base in the cerebellar, and marked irregularity is also seen in the cerebellar gait. Shortened and mild irregular steps length in the Parkinsonian gait, and the broad-based, short-stepped irregular walking in the frontal gait we can see. So what are the common terms which we use in the gait cycle? So cadence. This is number of steps in unit time or rapidity of the steps. Normal, it will be 90 to 120 steps per minute. Stride length. So the distance covered during the one full gait cycle, it's called stride length. That is 1.3 to 1.5 meters. It will be shortened in the pyramidal tract dysfunction or hypokinetic movement disorders, and rarely increased in the vestibular dysfunction or cerebellar ataxia. Step width. Step width is side to side distance between the feet, between the each medial malleoli. So few books have suggested 8 centimeters is normal, and few till 12 centimeters it was suggested as normal, and above 15 is considered as wide base. Next, step height. Maximum distance between the forefoot and the ground during the swing phase, that is equal to 1 to 2 centimeters. Symmetry. Comparison of the single length and timing between the left and right legs. May be asymmetrical in the unilateral cerebellar or sensory ataxia. Coordination. This is timing of a leg activation with respect to the other leg in the gait cycle. It should be smooth and well coordinated. Variable step timing can be seen in basal ganglion disorders or also seen in sensory or cerebellar ataxia. So equilibrium. Stability when standing is static equilibrium. It relies on musculoskeletal linkages between the trunk and leg. Postural reflexes are also, we have in postural reflexes, writing reflexes and anticipatory movements. Anticipatory movements are when we are walking, there is an anticipation that the weight will be kept on one leg, or when we want to stand. So there is an anticipation of that movement. For that, the body will be prepared. Writing reflexes are not the anticipatory, but any sudden movement or any change in the movement which can protect the body from falling. That these are writing reflex reactions. Sensory inputs also are required from the vision, vestibular system, and proprioception. Next, dynamic equilibrium is a key to gait, especially while turning the movements, obstacle avoidance, and postural adjustments. So I'll go into the history, ma'am.
Yeah, please go to the history part.
Okay.
One thing. Just go back to the slide about anatomical representation of the gait.
Yes, ma'am.
Okay. So just tell me what is the main center in brainstem which is responsible for gait?
Uh, Ma'am, midbrain.
See, there is a this
Miss.
furunculopontine nucleus is there.
Yes,
Okay.
ma'am.
So what happens? There is a brainstem locomotor area and there is a cerebellar locomotor area. And from there, the fiber comes to your pontomedullary reticular system. So,
Yes, ma'am.
you know, descending motor pathway, there is pontine reticulospinal tract and medullary reticulospinal tract.
Yes, ma'am. Yes, ma'am.
Okay. So the ponto reticular retractor, this works along with the vestibular spinal, causing the
Yes, ma'am. Yes, ma'am.
increase in tone in lower limb extensor muscles.
Yes, ma'am.
With that, the medullary reticular spinal, this works in the flexor muscles,
Yes,
mainly in
ma'am.
upper limb, but in lower limb as well. So with that, you are sending actually the inhibitory response to your lower limb muscles or the axial muscles at the time of locomotion. Okay. And the
Okay, ma'am.
medullary one is sending the excitatory information. So there is a spinal interneurons, which is called the
Yes, ma'am.
central pattern generator. So what happens whenever you are walking, both information is coming. So your brain, the frontal area, from where this information is going to come finally, that start the coordination. And from there, the information transmits to this lower part, that is the spinal area. And then finally, it coordinate over there. Okay.
Okay,
So
ma'am.
pontomedullary reticular formation, so there is it's some design to which pathways mostly mainly to the pontus reticular system and the medullary reticular system. Okay.
Okay, ma'am.
Yeah. Please continue for the history part.
Oh,
Yeah, I welcome Dr. Sheikh After Pasha, sir. He also
Yeah, yeah,
joined. So
yeah,
we'll
yeah.
continue.
Yeah,
Thank
please
you,
go
sir.
ahead. Thank you.
Okay.
so I've just completed the anatomy part, sir. We are going into the history.
Yeah, please go ahead.
So
Thank you.
approach to the history in the patients with the gait disorders or falls. So first question would be any abnormality or change in the gait. Is the patient walking slower or taking more steps, having difficulty turning, having difficulty going up steps, or veering on to the any one side? Or and we have to ask about the any history of the falls. If we have the history of the falls, we have to ask every fall history, like if they have some for 3 to 4 falls, how they have fallen, from the circumstances of the falls, how the frequency of the falls, any prodromal symptoms just before the fall, if they have any syncope or pre-syncope events, or the fall happened while getting up from the sitting position. So any prodromal symptoms also to be inquired. Any history of loss of consciousness, if so, what is the duration of loss of consciousness, if any history of the seizures are there, or is it is it because of any startle sensitivity, the fall, or excessive daytime sleepiness if it is there, and falls precipitated by any strong emotions, or any history of any headaches, migraine attacks, associated weakness, or any vascular risk factors. We should also ask about the history of any sensory loss, paresthesias, limb weakness, stiffness, or joint pain, or swelling, or contracture. And we have to ask about the history of visual impairment, hearing loss, tinnitus, or vertigo. And history of the cognitive impairment is also important, or abnormal involuntary movements, any drug exposure or alcohol or toxin exposure should be asked. So subtle deficits such as difficulty in putting on undergarments or trousers requiring balancing on the leg, so on one leg. This also will give us a small details into the falls. And any modifying or exaggerated factors like walking become more difficult in the dark, or walking more difficult while when distracted by the external stimuli, walking more difficult in the crowded places and in patterned or glazed floors, and gait improvement with suggestions and trivial support should be asked. So any other neurological deficit or possible etiological factors should be inquired in the history. So we have to ask about the history of the weakness. So many patients attribute any gait or balance problem to the leg weakness, even though none is detected on examination. However, the weakness of the certain muscle groups produces characteristic difficulties during the pattern movement of the gait cycle. So if they have the foot drop or spastic equinovarus, they have catching or scraping a toe, like tripping on the toes on the ground and tendency to trip. If they have the quadriceps weakness, they may present with the buckling of the knees or sensation that the legs will give away while standing or walking downstairs. And if there is any ankle or plantar flexion, they may say shallowed steps or high steppage gait, like they have to lift the whole leg to move. And if they have any proximal weakness, they may give the history difficulty in climbing stairs or raising from a seated position. And if any axial weakness is there, they may complain of difficulty of turning in bed, raising head from the pillow. And to history, in the history wise clues about the hypokinetic movement disorder, we have to ask about the slowness of the gait, shuffling gait with the short shallow steps, and difficulty. So while asking about the hypokinetic movement disorder, we should ask about the slowness of his movements also, because there may be a lower limb parkinsonism kind of features in the higher gait disorders. So, and difficulty initiation stepping while when starting to walk, this is called start hesitation. When an obstacle is encountered, or turning are common in the advanced stages of parkinsonism. Also history for the spastic paresis or the hemiparesis, we have to ask about the complaints of stiffness, heaviness, or legs that do not do what they are told, history of dragging their legs, catching the toes of their shoes, or any surface irregularities. Legs may suddenly give away, causing stumbling and falls. In some patients, muscle tone may be normal when supine, and leg stiffness may only occur while walking. This will be seen in mild spasticity. Similar dystonia, similarly, dystonia in children, like exercise-induced foot dystonia in adults, may be evident only on walking or running. So, difficulty raising from the chair or turning in the bed, and a general decline in agility may be due to loss of truncal mobility in diffuse cerebrovascular diseases, hydrocephalus, and basal ganglion diseases. And going into the history of imbalance, complaints of the poor balance and unsteadiness are the cardinal features of the cerebellar and sensory ataxia. But they may also seen in other neurological disorders and are particularly common in elderly. For clues for the cerebellar ataxia, unsteadiness, staggering, inability to walk in a straight line, and near falls. Turning and suddenly changing direction results in the veering to one side or staggering as if they're intoxicated, exaggerated by uneven support surfaces. And for sensory ataxia, we get clues like they have difficulty or unsteadiness while walking in the dark. Also, complaints of being uncertain of exact position of their feet while walking. They may give other complaints for the sensory problems such as numbness, paresthesia, cotton wool sensation in the feet, or inability to appreciate the texture of the ground beneath their feet. And for vestibular ataxia, we can ask about veering and sense of imbalance while walking in the environments when many moving objects, such as like in crowded street or shopping malls. For a few other favoring history of the favoring for the higher level gait disorders, such as in higher level like subcortical cerebrovascular disease, imbalance in manifesting when turning while walking, stepping backward, bending over to pick up something, or performing the several tasks simultaneously, such as walking and carrying your objects, walking and talking. So this gives the history from this. So falls are defined as reflect an inability to remain upright during a postural challenge, whereas drop attacks are defined as they are described as a sudden fall occurring without a prodrome that may or may not be associated with loss of consciousness and cannot be prevented by assistive devices. So I'll go forward, ma'am, for the falls and its types.
Yeah, you can go forward. One thing,
Yeah.
just tell me that one more
Yes, ma'am.
history should be asked. Whenever you are taking history of gait or they are giving complaint of imbalance, ask about the nature. I mean, whether it's a paroxysmal kind of gait imbalance you're encountering or whether it's a regular thing for them. And
Okay,
along
ma'am.
with it, ask about the history of jerkiness. Jerk in the sense, for example, if the person is driving a bicycle and at that time they encounter sudden jerk and then they had a
Okay,
fall,
okay,
and
ma'am.
after that
Anything
they returned
related
with
to?
consciousness. Yeah, so CV junction anomalies or the this atlantoaxial dislocations, they usually present in this manner, and for the short duration, they will be just having impaired consciousness, and after that, when they encounter the severe jerk, they develop a quadriparesis later on. So these kind of history should also be asked in when you are taking the
Okay,
history
ma'am.
of falls and gait.
Okay.
Okay, please
So
continue.
okay, going further, falls and its types. There are different types of falls like collapsing falls, drop attacks, and sudden loss of muscle tone, toppling falls, falls with retained muscle tone, drifting and falling while standing, falling while changing posture or position, weaving from side to side, then falling, tripping, freezing, falls due to vestibular dysfunction, sensory falls due to impaired sensory function, non-pattern falls. So collapsing falls or drop attacks, as we all so this is commonly described as loss of postural tone, sometimes referred to as drop attacks. This is consciousness is retained or fleetingly clouded, no post fall confusion. Common causes for the collapsing drop attacks are akinetic seizures, negative myoclonus, syncope, and ortholytic crisis, any orthostatic hypotension. Next, toppling falls. Falls with retained muscle tone. These are characterized by characteristics of toppling falls are patient falls in some direction and does not just collapse. They topples like a falling tree, drifting off the balance with no apparent effort to correct the balance. So these may be due to because of inadequate postural control. This is seen in PSP. Usually it is a backward fall. MSA, late IPD, frontal gait disorders. Due to disorganized synergetic contraction of the muscles required for the postural control, especially when rising from lying to sitting and sitting to standing position. For example, when a patient tries to get up from sitting to standing position, but does not bring the feet under the chair to keep his center of gravity between the feet, or if the patient while standing may drift out of equilibrium due to the distorted sense of body verticality. This is called as thalamic aesthesia, putaminal aesthesia, and Pusher syndrome. So Pusher syndrome is a latropulsion. This is usually seen in stroke patients where the individuals actively push themselves toward the hemiparetic side, resisting the postural correction and leading to the significant balance and gait impairment. Due to the problems with balance, patient may weave in any direction while standing due to increased body sway, resulting in a fall. But unlike in the previous situation, they retain the protective responses if the problem is in the balance. Other types of falls like tripping falls occur while walking when the feet do not clear the forefoot off the ground adequately. This is seen in foot drop or spasticity or parkinsonism. Freezing falls occur due to the freezing because of the feet get stuck to the floor when walking or during the initiation of the gait while the center of mass continues to move forward. Similarly, falls can occur during the festination because steps became progressively short with increasingly speed and are inadequate to keep the feet under the moving center of the mass. This patients typically fall forward on their outstretched arms. So next, falls due to the vestibular dysfunction. vestibular patients tend to drift towards the side of the labyrinthine lesion. This is more when the patient closes his eyes or in the dark or in the sensory conflict situations, such as when the patient is walking or moving on a moving platform. This type of falls can occur in both peripheral or central vestibular lesions, peripheral such as ophthalmic crisis and vestibular paroxysm. Other types of falls like sensory falls. Sensory falls occurs more commonly while walking on an uneven surface. And patients generally are aware of their balance deficit and try to protect themselves by using their arms to grab on a near object or voluntarily sit down to prevent the injury. And they also try to compensate their balancing deficit with the help of other sensory cues. Like their eyes are glued to the floor, like which helps visual input helps them to the walk. And other one is like non-pattern falls. In this case, the falls do not seem to fit in any consistent pattern. Abnormality represents the failure of attention and insight, resulting in the carelessness. The patient seems unconcerned about the fallings and its consequences. This type of falls is usually due to dementia. So and other points we are not we can't miss about the in the history about the falls are history of any urinary urgency or incontinence. This favors localization for the spinal cord, parasagittal frontal lobe, or subcortical dementia. Urinary symptoms can also be a part of non-motor symptoms of PD. And cognitive impairment like higher order gait disorders we can see is also associated with the slowing of the gait speed, executive dysfunction, inattention, impaired multitasking, set shifting may predict later development of the falls in older adults without dementia or impaired mobility. Dementia with disinhibition and impulsivity is also associated with the reckless gait patterns and falls. So and drug use or toxins or alcohol exposure, and like drug uses like sedatives can also cause the falls. Sleep history and joint pain, any joint pains can cause like antalgic gait, or any joint deformities also should be inquired in the history. So I'm going into the examination of the gait and balance.
Yeah, am I audible?
Yes, ma'am.
Okay. Just tell me that how on the history basis you will differentiate between the vestibular gait imbalance versus the cerebellar gait imbalance, or the
uh,
vestibular ataxia versus cerebellar ataxia.
Ma'am, vestibular basically they will have difficulty walking in a narrow pathways, ma'am. Not narrow, like many people, like crowded areas. In crowded areas or moving objects like escalator, if they're walking on it, they may have the difficulty. And cerebellar, they have difficulty in the narrow pathways.
And
And
along with that, actually, yeah, and along
ma'am,
with
you are
that, the
not
vestibular,
audible.
yeah, am I
Yes, ma'am.
audible? Yeah,
Yes,
okay.
ma'am.
The vestibular patient, because of the vestibular dysfunction, they try to keep their head in one position. If you just try to move their head, it will just highly worsen their ataxia. So
Yes,
that's
ma'am.
the thing that you will ask, that if they move their head or if the head is in a particular position, at that time, is there any worsening of the ataxia or not? Okay.
Okay,
For the
ma'am.
cerebral patient, the head position won't just worsen the ataxia that much.
Okay, ma'am.
Okay. Anything else, sir? Sir, anything else?
Yeah, you're asking me?
Yes, sir. Yes, sir. Can we continue, sir, or
Yeah,
anything
yeah,
else,
please go
sir?
ahead. Please go ahead. Yeah.
So examination of the gait and balance. So examination should be done under the six major headings. We have to ask the patient in a seated chair position. Ask him to arise to stand from a seated position without any support. Stand, and then he have to start walking. Turn. We'll walk a certain distance and ask him to turn while walking. And other maneuvers also we shouldn't miss the motor, sensory, and skeletal examination. So, erasing to the stand from a seated position. Here, the main muscles used are proximal muscle strength and organization of the truncal and limb movements, stability, and stance base. Standing, while standing, posture, stance base, body sway, Rombox test can be done when he stand. and pull test also to be done here. So I'll explain it later. Next, walking. Initiation of the walking, speed of the walking, stance base, width, step length, cadence, rhythm, and tempo of the stepping, step trajectory, whether it's a shallow, shuffling, or high stepping, and associated trunk and arm movements, trunk posture, turning while walking, number of steps to take the turn, stabilizing the steps, en bloc, truncal and limb movements, and any freezing while turning. Other maneuvers are like we have to check for the tandem stance, the tandem walking, walking backward and running, standing and walking on the heels or toes. If any subtle weakness is there, it can be seen. And Rombox test can be done for the sensory, and Fakuda test and can be seen for the vestibular, and dual task maneuver, such as walking while talking or walking while carrying on objects. These are the extra maneuvers. And finally, motor, sensory, and skeletal examination should be done. So, erasing to stand from the seated position. The main helps. The main here is, as we already told. So, watching the patient rise from the chair without using the arm informs the examiner about the patient pelvic girdle strength, control of the truncal movements, coordination, and balance. Inability to rise when the feet are appropriately placed under the body without using the arms while sitting and trunk is leaning forward may indicate the proximal weakness. Or any abnormally wide stance base when rising to stand from a seated position often signals the incoordination or imbalance. Inappropriate strategies in which the feet are not positioned directly under the body or trunk leaning forward while the person is trying to stand are seen in frontal lobe diseases and higher level gait disorders, such as a PSP. We can see the rocket sign. This is called as rocket sign in PSP. Standing. So posture, the trunk is normally upright during the standing and walking. So abnormalities of posture are like flexion of the trunk and stooped posture. This is characteristic feature of PD. Slight flexion at the hips and low to the lower the trunk, commonly in unsteady or cautious gait syndromes we see this. Upright posture with the neck and trunk extension is a typical of PSP. Forward flexion of the neck can sorry can occur with the weakness of the neck extensors in a motor neuron disease, myasthenia gravis, and some other myopathies. Can also present as an anti-colis dystonic manifestation. Also, this can be seen in MSA or PD. This dystonia. Lateral trunk flexion or Pisa syndrome is seen in PSP. Camptocormia, bending of the trunk, is seen in PD. Exaggerated lumbar lordosis, this is seen in stiff person syndrome, proximal myopathies, and paraspinal muscle spasms. Lateropulsion. This is mainly seen in and acute vestibular imbalance or lateral medullary syndrome towards the side of the lesion, and posterolateral thalamic lesions also we can see this. And continuing the standing, the width of the stance base. So the distance between the feet when rising from the sitting, standing, walking, and turning. This give the indication of the balance, which is normally 5 to 10 centimeters. So if it is more than 15, we consider as widening. So widening is an efficient method of reducing the body sway in lateral and anteroposterior planes. Person whose balance is insecure for any reason, they tend to adopt a wider stance, assume a posture of mild generalized flexion, and take shorter steps. So wide-based gaits typically are seen in cerebellar or sensory ataxia. In mild ataxia, may be evident only on turning. In very mild cases, it is evident on turning or may disappear while walking in a straight line. This may also be seen in diffuse cerebrovascular diseases and frontal lobe lesions. And aversion of the foot is a strategy to increase the stability, and particularly commonly seen in patients with diffuse cerebrovascular diseases. And reactive postural responses are examined by pull test, or sharply pulling the upper trunk backward or forward while patient is standing. So a few short shuffling steps backward or an impending fall backward or forward suggest an impairment of the writing reactions. Falls after the postural changes, such as arising from the chair or turning while walking, such as the impaired anticipatory postural responses. So pull test, for doing the pull test, the examiner the test examines the response of the sudden body displacement produced by the quick forceful pull on the shoulders while the patient is standing erect with the eyes open and feet comfortably apart and parallel to each other. We will test the retropulsion. We have to stand behind the patient and instruct the patient on what is about to happen. Explain that she or he is allowed to take a step backward to avoid falling. There should be a solid wall behind the examiner, at least 1 to 2 meters away, to allow for the observation of number of retropulsion steps. The first pull is an instructional demonstration and is purposely milder and not rated. The second time, the shoulders are pulled briskly and forcefully towards the examiner with enough force to displace the center of gravity, so that patient must take a step backward. The examiner needs to be ready to catch the patient but must stand sufficiently back so as to allow enough room for the patient to take several steps to recover independently. Do not allow the patient to flex the body abnormally forward in anticipation of the pull. Observe for the number of steps backward or falling. Up to and including 2 steps for recovery is considered normal. Abnormal rating begin with 3 steps. If the patient fails to understand the test, the examiner can repeat the test so that the rating is based on the assessment that the examiner feels reflects the patient limitations rather than misunderstanding or lack of preparedness. So zero normal, so no problem because within 1 or 2 steps. So one is slight 3 to 5 steps, but the subject recovers unaided. Mild postural instability, uh, more than if the patient takes more than 5 steps but subjects recovered unaided. Moderate instability is like stands safely but with absence of postural response, falls if not caught by the examiner. Severe is very unstable, tends to lose balance spontaneously or with just a gentle pull on the shoulders. So next, walking. We in walking, first to be
So,
checked is
Dr.
initial.
Tanya, yeah,
Yes, ma'am.
Dr. Tanya, wait. So that was which trading that we have told? It is UPDRS, I think. Yeah?
Ah, yes, ma'am.
So this is UPDRS reading of full test
Yes, ma'am.
because there are different readings has also been given.
Okay.
Okay. So when you stand from the sitting position, can you tell me the muscles which are involved, or what are the muscles that weakness you will see when the person is standing from the sitting position?
From the chair, ma'am.
Yeah, from the chair.
Oh, while standing, this proximal lower limb and the trunk, ma'am, like mainly quadriceps, primary extensors, like quadriceps, this helps in the knee extension for the initial push, and they also should have the gluteus maximus for the hip extension, and
Along with.
for the hip stabilization, for pelvic stabilization, we need gluteus medius and minimus. And for
Yes.
truncal posture, erector spinae muscles, paraspinal muscles,
The
and
truncal
also
paraspinal muscles. And
and also I think abdominals also. I'm not sure about the abdominals, ma'am. Like rectus abdominis and obliques for the stabilization of the trunk. Whether
yes, and along with that, the foot muscles
and
to
yes, ma'am.
stabilize on the foot. Okay. Okay. So, okay, please continue after that.
Okay. So walking, so initiation of the gait, initiation difficulty ranges from start hesitation to slipping clutch phenomenon to magnetic feet phenomenon. Patient may use exaggerated upper body movements or alter the step pattern, such as stepping sideways or lifting the feet very high in an effort to engage their legs in the motion. So stepping, the length and the trajectory of the each step and the rhythm and tempo of the stepping should be noted. Short, regular, shallow steps or shuffling and a slow gait are characteristics of akinetic rigid syndrome. Shuffling is most evident when they're starting to walk, stopping or turning the corners. Freezing typically occurs during the turns, when walking in the confined spaces, after encountering an obstacle with visual distraction, such as walking through a doorway, or if any attention is diverted for any reason, we may have the freezing. Festination, increasingly rapid small steps is common in the PD, but rare in other kinetic rigid syndromes, and which are frequently associated with poor balance and falls rather than festination. And jerky steps of irregular or variable rhythm, length, and direction suggest ataxic or choric syndromes. And types of freezing are start hesitation, freezing when the gait is initiated, turning hesitation, freezing when turning, destination hesitation is when the approaching the target, freezing when an obstacle is encountered, or spontaneous sudden transient freezing also can be there, palilalio or freezing of the speech, or apraxia of the eyelid opening or levator inhibition of freezing, or freezing of the limbs. So going into the walking and turning slowing on turns may be the first abnormality in a walking in a patient with PD. Multiple steps on turning are common in PD and diffuse cerebrovascular disease. An extra step or mild widening of the base on the turning may herald the onset of the ataxia. So more challenging test of walking, as we already discussed, like walking on toes and the heel, which may bring out abnormal movements or dystonia, and also reveal subtle weakness of the dorsiflexion and and plantar flexion of the ankle, and associated synergetic limb movements while walking. Any unilateral loss of associated synergetic arm swing while walking is valuable sign for the early PD, but may also be seen in acute unilateral cerebellar lesions and hemiparesis. Exaggerated arm swing is observed in a military two-step gait of a marchy petit pas. Involuntary movements are often superimposed or synergetic arm swing during the walking. Dystonia or chorea may also become very prominent on walking than on the rest. Other maneuvers are tandem walking, abnormal in cerebellar dysfunction, Parkinsonism. Walking backward, this helps to see for the dystonia. This because walking backward improves the dystonia in most of it, except for the DYT1 and tardive dystonias. Walking on the toes and the heels may bring abnormal movements or dystonia. This already we've discussed. Walking with dual tasking, like walking worsens gait difficulty in elderly or subcortical dementia. Patient is asked to perform mental arithmetic or some task with the upper extremity while walking. So, going into the gait disorders, this can be due to peripheral dysfunction or central dysfunction. Peripherally, due to the joint disease, pain, muscle weakness, sensory loss. Central dysfunction is due to impaired postural control, due to impaired balance, impaired stepping. So, anatomical and physiological classification, gait disorders are classified into lowest level disorder, middle level, and highest level gait disorders. Lowest level
Wait, wait,
is
wait,
main. Yes, ma'am.
Dr. Khanna. Just tell me how
Yes.
to do Romberg testing. How was it originally described by Romberg, and what modifications has been done in this?
Romberg test, mainly we will ask the patient to keep the feet together and stand and then close the eyes, ma'am. This is mainly to determine the unsteadiness of the loss of this proprioception input, anything. First, initially, we'll keep the feet together, ask eyes open, and then see after if they're maintaining. Then, while maintaining the same posture, we'll ask to close the eyes.
Okay. So actually, the Romberg, when historically, when he originally described this Romberg sign or the gait instability, so what was it? He just said the person is able to maintain the posture in the eyes open, and when he is developing the unsteadiness with the eye closure was actually the Rombergs. He actually never described this thing, that whether the foot must be closed or the your hand should be outstretched. So these were actually the later on modifications that were
Okay,
done.
ma'am.
Okay. So in Romba, the basic thing you have to just make the patient first comfortable in whatever position he can stand. And then
Okay.
just ask him to close his eye and just see whether he is having any swaying or any instability during that time or not. Okay.
Oh,
Then you do the
okay.
modified one that we do, that we ask the person to be barefoot. It's again a modification. You just ask them to be the barefoot, keep both the foot closed, and then you see how is their posture, whether they are swaying to either side or not. Okay. And
Okay.
then you will ask them to outstretch their hand. Then again you will see in the eyes open condition, and then you will ask them to eye close. Because to test that the Bromberg is positive, there should be a disproportionate worsening from the eyes open to the eyes closed.
Eyes closed.
Okay. And when a person is actually having a swing while eyes closed, is it just proprioceptive? How will you differentiate whether it's a proprioceptive, it's cerebellar, or it's vestibular?
If it's cerebellar, when they keep the feet together itself, they will not have the balance, ma'am. If it's the
In
cerebellar
yes, in cerebellar, the swaying will be almost same when it's the eyes open or it's the eye
or
closed. Okay.
eyes closed, yes, ma'am.
Yes. And to differentiate from vestibular, it's actually called a Roper's refined Bromberg's test. So what do you say? You just ask them to turn their head side to side, and then you see if there is a worsening in their imbalance or not. Or
Okay,
this
ma'am.
is actually
Okay.
eliminate if the person is having a normal vestibular, so this will eliminate the vestibular part. And then if they are having imbalance, this is purely the cerebellar.
Sorry,
Okay.
ma'am, I didn't understand the last one. For the
Okay.
head-to-head
Then
movement on the sideways, which will help us
you
to.
just ask them to turn the head side to side. So if they are getting any kind of vestibular clues,
Okay, ma'am. Okay.
see, your person is having swing as soon as you ask them to close the eyes, but might be because of vestibular clues, they are able to maintain their posture somehow. So as soon as you ask them to just turn their head side to side, so what happens? The both side of vestibular system now they are not working that much. They have just
Okay.
nullify each other.
Okay. Yes, ma'am.
Okay. So now what remains? Cerebellar already gone,
Mm.
optic already gone, vestibular gone. So it will be the proprioceptive.
Proprioception.
That
Yes,
is
ma'am. Okay.
that you will see. So what is this called? This is called as a Roper's redefinition of Bromberg's test.
Okay.
Okay. Okay. Please continue.
Okay. So, going into the anatomical and physiological classification of the gait disorders, we have lowest level, middle level, and highest level gait disorders. Lowest level is mainly because of the elemental disorders like muscle, nerve, roots, neuromuscular, includes consequences of any sensory deficits like peripheral neuropathy or any vestibular or visual problem. Middle level is central motor system disorders, and will highest level disorders. So in the lower level, as we told, it includes myopathic gait, neuropathic gait, quadriceps gait, and sensory ataxia or stomping gait, vestibular or weaving gait. In middle level, because of the motor system, like they may have spastic gait, cerebellar gait, hypokinetic gait, choric gait, and dystonic gait. In higher level gait disorder, it can be anterior or posterior higher level. Mainly in anterior, we can see as advanced Parkinson disease, PSP, NPH, subcortical vascular dementia, and parietal infarcts in posterior, and thalamic infarcts and Pusher syndrome. So for the lower, going into the lowest level gait disorders, if there is a hip abductors muscle weakness, they may have waddling gait. If there is a distal weakness like weakness of the foot or dorsiflexors, we see a stepping gait. Because of the foot drop, they have to lift the whole leg and then keep. So this sees as a stepping gait. In quadriceps gait, because of the quadriceps weakness, at each step on the affected leg, the knee hyperextends and the trunk lurches forward. And other one is antalgic gait. This is also called as pain avoidance gait. So if they have any joint pain such as arthritis or any sciatica or hip or knee joint pathology, the shortened stance phase will be there in that side of the leg, and limp may be present. So for the limb middle level central motor system disorders, limb hypertonia or hemiparetic gait or circumduction gait is seen. So spasticity is mainly characterized by leg extension and plantar flexion of the foot with leg circumduction and hip flexion. This is associated with an intermediate abduction of the ipsilateral arm with each step. when it is unilateral. When it is bilateral, it is seen as a scissoring of the legs, also called a scissoring gait, with bilateral circumflexion. There may be slight flexion at the hips and the knee when standing, but on starting to walk, the affected leg stiffness and extends slightly at the knee. So spastic gait typically worsens when the patients are instructed to hurry up, since spasticity is a velocity dependent. One should be aware that the stiff gait may not only be due to spasticity or rigidity, but can also be seen in the peripheral causes such as stiff person syndrome, neuromyotonia, and myotonia. And as this we already discussed in paraparetic, stiff-legged gait is also seen in stiff person syndrome. And ataxic gait, cerebellar ataxia, dysmetria, dyssynergia, performance variability, poor balance, gait disorders. So they may have clinical features such as irregular stepping, direction, distance, timing, lurching, poor upright stability, falls, and they may present as a broad base. So next is middle level. We can see Parkinsonian gait. So stooped posture with a narrow base, and camptocormia may also occur. Poor balance with falls, short shuffling steps, often with festination. They may have the en block turning, reduced arm swing, hand tremor, gait initiation difficulty, and freezing is common in both off and on states in about one-fourth of the patients by the 4 years of the PD. And so gait speed is slow and slows with progression. When the walking faster, patient increases the step rate more than the stride length. So there is a variability of the stride. There will be a stride length variability which is associated with the falls, and stride time variability independent of tremor, rigidity, Parkinsonism. This may be because of the levodopa responsiveness, and dual tasking markedly increased variability will be seen. And dystonic gait, this is a early common sign, the inversion of the foot during the walking. Great toe may be flexed or extended, and this they may have action dystonia. This is not present at the rest. In action dystonia, with progression, there will be abnormal posturing of the leg, trunk, and arms. This may resemble as dancing gait of Korea. And task specificity, walking backward may be better, running can be spared. Can look very unusual. We have to distinguish from the psychogenic. Camptocormia is a spinal flexion is one of the such poster with psychogenic as a principal differential. And choric gait is often called as dancing gait, represents chorea superimposed on locomotor movements. Uncoordinated stepping, dysmetric appearance like a ataxic gait is seen in choric gait. Bouncing gait or myoclonus. Here, the myoclonus affecting stance and gait gives rise to characteristic bouncing, and the appearance is due. I'm sorry, I have not finished this. So we'll going into the highest level gait disorders. This is coming from the malfunction of the cerebral hemispheres. These disorders are not completely distinct. Patient may have characteristic of more than one or may progress from one to another. So this also includes highest level also includes functional gait, also called psychogenic gait, and arising from the psychiatric origin, such as and also cautious gait. There will be a subcortical disequilibrium. Severe impairment of the balance will be there, arises from the dysfunction of the midbrain, basal ganglion, or thalamic levels, often seen in PSP, Parkinsonian plus disorders. And this is called as thalamic aesthesia. By etiology, really misplaced, and this belongs into the middle level category, but perhaps combined represents as a combined basal ganglion and cerebellar balance disorder. So, in higher level gait disorder, the next three conditions described are frontal disequilibrium, isolated gait ignition failure, and frontal gait disorder. In frontal disequilibrium, balance difficulty and I'll discuss them later. And these three also presumptively anatomically, they are also named as other condition called as ignition apraxia, equilibrium apraxia, mixed gait apraxia. So basically, frontal lobe is like apraxia. Ignition apraxia is there is a damage predominantly in the SMA and its connection. So but there will be a good response to the external clues. And in equilibrium apraxia, damage predominantly in the premotor area and connections, poor response to the external clues. Mixed gait apraxia will have mixed features. So this frontal disequilibrium is a loss of balance accompanied by disordered stepping that is difficult to describe. Stepping disorder is termed as apraxia. By some, it is termed as ataxia. And apraxia concept is like leg movement unrelated to walking seem reasonably good, such as if we ask the patient to lie down and do a bicycling movement, they will be able to do. But when we ask them to walk, they may have difficulty in walking. So only they have difficulty only in the walking, but other movements they can do it. And this is associated with frontal lobe signs suggestive of frontal origin. Isolated gait ignition failure. This is difficulty in initiating and sustaining the locomotion. Freezing, particularly when getting started, also termed as primary progressive freezing of gait. Balance can be good. Steps begin short and gradually increase in amplitude. Patient may say they walk normally once started, differs from the festination. In festination, stepping never appears normal. In this, it will become normal as they walk. Other one is frontal gait disorder. Initially, this resembles as Parkinsonian gait, like short shuffling steps, poor balance, initiation failure, hesitation on turns. The main differentiating feature for this frontal gait disorder is this is more upright stance. There will be no tremor, and they may have frontal lobe signs and apparent involvement of only lower body. So this is also called as lower half Parkinsonism or lower body Parkinsonism. Can evolve to the frontal This can evolve into the frontal disequilibrium with difficulty to describe the stepping disorder, and these people they will not respond to the levodopa. So gait in normal pressure hydrocephalus, this is more studied, and many patients have freezing and great apraxia. There will be a decreased stride length and reduced foot floor clearance. Compared with the PD, NPH patients are slower and shorter stride length. And next, cautious gait. Some, particularly in the elderly or the patients with, if they have the prior falls, this is main term used is space phobia. They have anxiety about falling, so such that they have this cautious behavior. So the eye gait resembles as if they're walking on a ice, wide based, slow, short steps, en bloc turns, and tense arms. Patients seek support and they improve markedly when they have it. So no overt freezing or shuffling is seen in cautious gait. And last one is functional or psychogenic gait. Common manifestation of psychogenic movement disorders, also known as aesthesia, abasia, or acrobatic gait. This is unusual. Gait is inconsistent, often dramatic stance and gait patterns with lurching, rarely falls. Even though if they have fall, there will be no injury. Sudden knee buckling without falling, and extreme slow motion can be seen. Sense of wasted energy. Sometimes, even though they may have many organic causes are there, they can present with the camptocormia also. And careful observation typically shows this excellent balance. There will be wide fluctuations over the short period. And possible clue we get is as if they have a facial expressions of strained or suffering, moaning, or hyperventilation. This can be multifactorial, particularly in the elderly. We see this, and additional causes should be identified. And this already we have discussed. So I've just summarized the gait disorders, ma'am. I'll finalize this. So in hemiparetic or circumduction gait, usual causes stroke and MS. Localization seen in the corticospinal tract, human lesion. Cadence will be slow. Stride length will be reduced. Short on only on the affected side. Step width will be normal. Step height will be like reduced. The toe will be dragged. Symmetry, asymmetry, only one-sided weakness, and there is a coordination, spastic and stiff movement on the affected side. And other abnormalities are circumduction, foot inversion, or hip height. In spastic paraparetic or scissoring gait, Also seen in this causes are hereditary spastic paraplegia, cerebral palsy. In this, bilateral corticospinal tracts are involved. The cadence is reduced, stride length is reduced bilaterally, step width is reduced, and narrow legs cross, and step heights will be normal. Symmetry is bilateral stiffness, and coordination, there will be reduced poor limb coordination. Knees will be flexed, toe walking, adductor tightness will be there. And in Parkinsonian fascinating gait, Parkinson's disease, PSP, MSA, affected localization is in basal ganglion, substantia nigra striatum. Cadence is increased, rapid short steps, and stride length is reduced, very short, and step width will be normal or sometimes can be reduced, and step height is reduced, arm swing is reduced, asymmetry in the early Parkinson disease, and there will be bradykinesia, freezing of the gait, difficulty turning can also be seen. In frontal or magnetic gait, it's seen in NPH, Binswanger disease, and frontal stroke. Frontal lobe, subcortical white matter lesion in localization. Cadence, stride length is reduced, and step width is increased, and the height is normal, often asymmetrical. There is a gait initiation failure. Feet are seen as if they are glued to the floor, and hesitation, difficulty with turns. In cerebellar ataxic gait, cerebellar stroke, MS, alcohol, cerebellar degeneration, localization affected in the cerebellum, and cadence can be normal or reduced. Stride length is irregular, reduced and irregular. Wide based gait, variable step height, high variability of lateral sway. There will be decrease in the cord, severe dysmetria will be there, and staggering, veering worsens with the tandem walking. In vestibular gait, it is veering gait. Causes are vestibular neuritis, brainstem stroke, Meniere's disease. Affected are vestibular nuclei, inner ear, brainstem. Cadence and stride length will be normal. Step width may be increased if it's chronic, and height will be normal. They will be falling towards the affected side. Coordination is reduced, impaired writing reflexes, and other abnormalities like this gait worsens with the head movement. Vertigo will be there. And dystonia, primary dystonias, Wilson's disease, tardive dystonia, affected in the basal ganglia, putamen and thalamus. Cadence and stride length will be variable. Step width will be normal or sometimes increased or sometimes irregular. Step height will be normal or increased in the hyperkinetic movement. And asymmetry, abnormal posture, excessive muscle contraction will be there. Twisting movements, difficulty initiating gait will be present. In apraxic gait, frontal stroke or CBD, supplementary motor area and parietal lobe is involved. Cadence and stride length is reduced. Step width is increased, and step length is normal. Symmetry is severe asymmetry. Coordination is reduced. Motor planning is planning failure, and difficulty sequencing movements inconsistent with the step execution. Uh, yes, ma'am. That's it, ma'am.
Okay. So, in if you are seeing a patient with dystonic gait, what things you will ask the patient, or what things you will notice?
Ma'am, there will be a twisting movements of the ma'am. Sometimes, if it's action dystonia, they may have only while walking or doing the specific task. Or if they have normally with at rest also, they'll have the twisting postures or repetitive movement will be there, and usually it is asymmetric. And if they walk, if we ask them to walk backward, the dystonia, the walking may improve than walking forward.
So, what happens actually, and sometimes in OPD or most many of the time you will see it's a difficult to see or differentiate from the dystonic from the spastic limb.
Okay,
Okay.
ma'am.
So what happens that in dystonic there might not be just a repetitive twisting. They might just have a posturing only.
Yes, ma'am.
Specifically, if they are having a posturing in the this there's a flexion kind of posturing at the level of foot. So there is a very common thing that you will get a confusion. So what you will see, you'll ask them whether it remains same all the time. Most importantly, whether it persists during the sleep or not. Okay. So if it get relaxed during the sleep, then most likely we are dealing with extrapyramidal rather than the pyramidal spasticity. Although
Okay.
the spasticity also reduces, but it won't be completely normalized.
No, yes,
Second
ma'am.
thing, if there is a diurnal variation, it's very important. The dopa responsive dystonia, in the morning they are absolutely fine. As soon as the day passes, there is a worsening of this dystonia movement or the dystonic foot posturing. So the diurnal variation must be asked in all these patients. Other than that, you will ask about the exercise or the movement, whether it worsen it. So that classical history you will get that when they start working, they are normal. But as soon as
Mm.
they continue to work after a certain duration or certain time, they start limping or they fall or they get this kind of posturing.
Okay, ma'am.
Okay, so that thing you should also ask. Whenever you are seeing a patient with posturing in the limb, then you should see. And along with that, you'll ask whether it's a lower limb only or the other part of body they are also
Any other
involved in.
parts of the, yes, ma'am.
Yes. So again, and other than that, whether they have received any previous treatment or they are on any drug.
Okay,
So their drug history should also be asked. Okay.
okay, ma'am.
Okay. Anything else, sir?
Yeah, Dr. Dhanya,
Yes, sir.
very good, excellent, exhaustive discussion on rather looks simple but very complicated topic, gait disorder. I just want to ask from where, what are all the references you use in preparation? You should
Sir,
please mention the references.
yes, sir. One I used from Jankovic, sir, like
Okay.
anatomy and the higher order gait disorders.
Mm-hmm.
And
Mm-hmm.
I also read from this spinal cord, the James Joe's book, sir. Spinomotor
Okay.
localization, James Joe's book.
Very good, very good. My view is like my request to you or any of the postgraduates for the lifetime preparation, like if you could have demonstrated video demonstration of these gait disorders or gait phenomena of a prototype case from each, you know, like you said, pyramidal, extrapyramidal,
Yes, sir.
cerebellar, vestibular, proprioceptive, like neuropathic, myopathic. If you could demonstrate the video demonstration of one gait. See, you told so much about stance, swing, single phase, double phase, cadence, step length, stride length, so much. Have you ever applied these things in your clinical practice? Answer honestly.
Like mostly while doing the care
You would
presentations,
not have done. You
other
would not
than
have done.
that.
See, yeah, I understand. Even if you ask me, sir, did you do all these things in your practice? No. See, the theoretical discussion, we discuss all this stride length, step length, so much of theoretical. But when you're in a busy clinic, what are you going to see when the patient, when it comes to you, you have got in emergency, you have got less than 5 minutes. You are in a rush to make a diagnosis and give a working uh, plan what to be done to ask for imaging, to ask for further tests, or to admit the patient, to send the patient home, or to send to other department. You should have a frame up. What I felt is like if you could have video demonstration of prototype disorders, what you paid is excellent table now, like
Yes, sir.
you written circumduction gait, scissoring gait, fascinating gating, magnetic gait.
Yes, sir. Yes,
If you
sir.
could have just less than 1 minute video of each of these case, and if you can show us, see, sir, this is how I see a patient of a hemiparetic gait. That will be a visual impression. See, the most of our memory image is memory based. Once
Yes,
we
sir.
look at the image, it's pattern based.
Yes,
Once we see, we will never forget in our life. So many postgraduates, about 24 students have joined this class. If they look at the once the memory or video of a patterned gait dysfunction, it for our life they will never forget. Okay, this is my request. Don't mind
okay.
that I'm making negative out of your presentation. I'm just giving
No, sir.
a
Yes, sir.
positive input, so because it will be beneficial me, for you, and for everyone, for you, for lifetime.
Yes, sir.
In future, if possible, in your clinical practice, na, record less than 2 minutes of video of this prototype get discussed. Okay.
Yes, sir.
Now coming to the clinical approach, when the patient has described everything, my question
Yes,
to you is, how do you approach a case of buckling patient? Buckling. Don't go back the slides. Just without going back to the slides, tell me what is buckling.
sir, while they're walking, when they have the sudden the buckling at the knees, sir, is
Very
seen
good.
usually in the like
Most
they
common
have a
complication.
sudden given
Most
away
common
of the knee,
complication. Yeah,
like
right.
quadriceps weakness, sir, myopathy, proximal.
Most common
myopathies,
cause is painful buckling, which is
pain,
most often seen in patients with knee osteoarthritis.
knee arthritis. Yes, sir.
Cruciate ligament dysfunction, semilunar cartilage dysfunction, and it is
Okay, sir.
painful, as you said rightly. Where do you get painless buckling?
Sir, myopathies, sir,
Yeah,
in
it
proximal
can
muscle.
contain three conditions: L3 radiculopathy,
Okay,
femoral
sir.
neuropathy, or it could
Yes,
be
sir.
UMN spinal cord, tarda equina syndrome. Okay,
Okay, sir. Okay, sir.
painless buckling you get in femoral neuropathy, L3 radiculopathy, and spinal
Spinal cord.
tarda equina
Okay, sir.
syndrome. Okay, good, very nice. You said as soon as the patient comes in with a walking difficulty, okay, what and all you see? Don't go back to the slide. Just speak out.
So whether once they come to the
Hmm,
us, we will see
hmm,
whether
hmm,
how they are
hmm,
walking, sir. Like
hmm, hmm,
whether, like we are sitting in OPD, we'll see how the
hmm,
patient is walking and coming,
hmm.
and
He's coming alone, and if he's brought in, is he
or
coming
whether he's
alone,
brought in
or is he
or
been
he's
brought in?
brought.
First point.
Yes.
Second point.
Second point, is he taking any support while
Hmm.
walking, or
Very good.
walking by himself?
Hmm, hmm,
Uh,
hmm, hmm.
and like usually OPDs will not be that big, so they may have, while getting entering into the gate itself, we can see if they are having the
Hmm,
freezing
hmm.
kind, that
Very
we
good.
can observe, sir.
Very good. Yeah, see,
Yeah.
at the outset, we see gate. What is there to studying gate? What is there to check in gate? There is nothing much to studying gate. So, the one who feels like that, they should attend your lecture. There is a lot to know in gate.
Yes, sir.
Okay, you said so much about the gate. When a busy clinical practice, less than a minute, you can examine a patient and you can identify, you can localize to the part of the brain where the problem is there
Yes, sir.
within 1 minute after examining his gait.
Yes,
All of what we say, motor, sensory, cerebral, proprioceptive, if you look at the gait, one can make the conclusion which part of the neuroaxis is being damaged.
yes. Damage.
Okay,
Yes, sir.
because gait is one which is the final output of several neural pathway, as you said, central, frontal, parietal, occipital, brainstem, you said, and
Yes, sir.
cerebellar, you said. Then down the pathway you have what you
Spinal
said,
interneurons,
vision,
sir. Spine
input is
inputs,
vision, vestibular,
proprioception input,
proprioception,
visual input,
and the
vestibular
output
input.
is by anterior cells, skeletal,
Yes, sir.
so much.
Yes,
So
sir.
it's the output of every neuroaxis is involved. You cannot pinpoint that this is only the part which is involved in gait dysfunction. Is every part of the neuroaxis is involved in production of the proper gait. Okay,
Yes, sir.
and what is Bruns ataxia? What is Bruns
Sir,
ataxia?
yeah.
Why I'm asking is you already described this thing
So
because you
this
have
is
noted down
in,
so many things. It's difficult to because the few of the things we memorize by
yes,
reflexly, few of the
yes, sir.
things we just mark up, few of the things we see and talk. You have written Bruns ataxia, frontal lobe ataxias,
Strong.
because frontal get disequilibrium. The three
Yes,
of
sir.
the frontal ataxias you written, the first
Yes.
of it, okay. And you
Oh,
said in freezing phenomena, you said so many of types of freezing, right?
yes, sir.
What is freezing? For your understanding, what did you understand by the term freezing?
Uh, like uh, like sudden, there is a brief episode or marked reduction in the progression of the feet for in the further
Simple,
move.
simple term, Danya, please.
Yes, sir.
Inertia of gait. Simple word.
Inertia. Okay, sir. Okay, sir. Inertia of gait.
Inertia of gait is called freezing. Okay. So it is due to what?
Uh,
This
It's due
can
to
be
freezing mechanism of freezing
maybe,
what?
sir, any abnormal gait
Mhm, mhm.
pattern generation,
Okay.
or
Okay.
any
Have,
problem in the central drive.
okay. So have you ever seen a patient of freezing? If you put some stick or your foot across or if some
Yes, sir.
obstacle in front, is freezing improves
Yes, sir.
paradoxically.
Yes, sir.
Have you
Yes,
ever
sir.
seen that?
I've
Why does
seen
it?
one patient
Yeah,
who
yeah, yeah.
walks with a stick in a different
Yeah,
patterns.
yeah,
He
yeah. Some of the
walks.
patients, some of the neurologists, some of the senior movement disorder specialists, even they say give a stick with a side rod to the patient, a person with a freezing with Parkinsonism who has a more severe freezing, because if you look at the stick in front, okay, his freezing improves. Okay,
Yes, sir.
what is the phenomena? Like, why does it freezing improves?
Basically, this is kind of apraxia, sir. Like they don't
Yes,
know, they're
that
not able
is.
to walk normally. So
Mhm.
when we keep some other thing, they use other pathway to move, start the initiation of the
Mhm.
movement.
Mhm. Okay. One more thing. What is this? You written Marches Petit Pass. What is that? Marches Petit Pass. You written 3 4 slides. You written
Yes,
this
sir. Yes,
word.
sir.
What is this?
This is seen in
What is the meaning of that term? It's not
like
English word. I know.
yes,
We
sir.
know. What is it?
Like like turning while walking, sir. Like this mainly helps in the balance, or like walking in a straight line where the first where the balance, like
Literal meaning of
abnormality
Marcha
is seen
Petit
in
Pass is
during
a
that time.
short shuffling steps.
Oh, okay, sir.
Short shuffling steps is been equivalent to that Marches Petit Pass. Whatever you said, seen in
Okay, sir.
Parkinson disease syndrome. Short shuffling steps is the synchronon is equivalent to that Marches Petit Pass. Okay.
Yes. Okay, sir.
Very good, Dhanya. Excellent presentation. But my request to you is, please, in future, if
Videos.
you are presenting second time, less than a 1 minute video of this prototype gait disorders,
Okay,
it
sir.
will be more helpful for the students to understand.
Okay, sir. Okay, sir.
Thank you
Sure,
very
sir.
much.
Thank you, sir.
Yeah, one question has been asked regarding what is the difference between gait apraxia and the frontal gait. Okay, so actually, the gait apraxia is not a true apraxia. What happened? The person is having an idea that how he can walk, but what is happening? They are suddenly freezing, or their limbs are normal. Their lower limb motor power is normal. Their coordination is normal. Everything is normal. The only thing they are unable to initiate that movement, such as you see in the freezing. So this is a commonly seen in the frontal gait disorder, just a part of that. And when you ask the person, how will you see that in the frontal lobe, the frontal gait, they will be having a short gait. They'll be just walking with a short steps and with a wide base gait, but they won't be able to initiate the gait. That is a initiation freezing that you commonly call. So that is a gait apraxia. And along with that, when you ask them to make a star from their foot, or whenever you ask them to make a circle from the foot, that they won't be able to make. So that is why this term has been given as an apraxia. It's actually all is a part of a frontal lobe, the frontal gate actually. Understood?
Yes, ma'am.
Yeah. Okay. So very good presentation, Dr. Dhanya. It was excellent presentation. And thank you everyone. Any other question?
Yeah, if there are no further questions, we will conclude the session. Thank you, Dr. Soumya and Afsar Pasha sir, for
Thank
moderating
you.
this session.
Thank you. Thank you.
And thank you, Dr. Dhanya.
Thank you, sir. Thank you.
Thank you, sir.